Welcome to the deep dive. Today we're peeling back the layers quite literally to explore the fascinating world of the integumentary system.
That's right.
Our trusted guide for this. Well, it's Chapter 39 of Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition.
A really solid resource.
Definitely. And for you, the learner, someone who wants to grasp these complex topics quickly and get those aha moments without feeling overwhelmed, think of this as your fast track.
Exactly. We're pulling out the core knowledge about skin, hair, nails, glands, basically giving you a clear, concise rundown of the nursing concepts you really need.
Kind of a shortcut to feeling confident about this system.
Precisely.
It's a big system. Did you know your skin is actually the largest sensory organ? It's like 15 to 20 square feet and weighs about 9 pounds.
It's substantial, and its main job really is being that first line of defense.
Your personal bodyguard, essentially, against infection, which, let's face it, helps everyone.
Absolutely. But it's so much more versatile than just a barrier. Think about it. It's constantly feeding information back to your brain. Touch, pressure, pain, temperature.
Right, how you physically interact with everything.
And it doesn't stop there. It helps regulate your body temperature, gets rid of some waste products.
Yeah, prevents dehydration.
Synthesizes vitamin D3, which is key for calcium metabolism.
And even stores nutrients. I mean, talk about a multitasker.
It really is. And understanding that basic structure, the epidermis on the outside, then the dermis, and the hypodermis or subcutaneous tissue below.
Plus the extras like nails, hair, the oil and sweat glands.
Yeah, that whole structure gives us the foundation. It helps us understand why things go wrong, why skin disorders develop.
It's like having the blueprint before you try to fix something.
Good point.
And speaking of defenses, it's interesting that our skin isn't actually sterile.
Not at all. It has its own community of normal bacteria, usually harmless, and they just shed off as skin exfoliates.
Part of the natural process?
And what's really neat is the skin's pH. It's slightly acidic, usually around 4.2 to 5.6.
Okay.
And that acidity actually helps keep a lot of harmful bacteria from growing. It's another layer of protection.
Clever. Okay. So, what messes this system up? What are the risk factors? Because they seem really varied.
Oh, they are. You've got environmental stuff, pollutants, radiation, and obviously sun exposure, tanning beds included.
Right. And then there are personal habits.
Definitely. Poor hygiene, using really harsh soaps or products that irritate the skin that can break down the barrier.
Makes sense.
Even some medications, especially if you're on glucocorticoids, steroids, long-term, that can make your skin more vulnerable.
It feels good domino effect sometimes. Internal factors, too.
Absolutely. Things like not getting the right nutrients, being under a lot of emotional stress, genetics play a role.
Repeated injuries.
Yeah, or irritation. Plus, systemic illnesses or anything that weakens the immune system that really ups the risk for skin problems, especially infections.
So any break in the skin, even a small cut, becomes a doorway for infection if your immune system isn't up to par.
Exactly. It really highlights how crucial that intact barrier is.
And we can't forget the psychological side of things. Skin conditions.
Yeah.
They can really impact how people see themselves, right? Body image.
Hugely. Lower self-esteem, feeling down. It's definitely more than just skin deep. People might isolate themselves, fear rejection.
Yeah, I can see that.
Plus, it can limit activities, cause pain, affect work, and then there's the cost of treatments. It adds up.
Okay, so if that barrier is breached and we get a wound, the body kicks into healing mode. What are the phases?
Generally, 3 main ones. First is the inflammatory phase. Starts right away, lasts maybe 3 to 5 days.
That's when you see the classic signs: swelling, pain, redness, warmth.
Yep, that's the body's initial alarm system going off. Then comes the fibroblastic phase, maybe day 4 up to a few weeks, sometimes 4.
Fibroblastic, so building fibers.
Pretty much. Fibroblasts make collagen, the scaffolding for scar tissue, and you get granulation tissue forming that pinkish, bumpy stuff that fills the wound.
Okay. And the last phase?
The maturation phase. This one can take a while. It starts around 3 weeks, might go on for a year or even more.
A whole year, wow.
Yeah, the scar tissue is remodeling, getting stronger. It might thin out, but it usually doesn't quite get back to the original skin's flexibility or color.
And how wounds heal?
Yeah.
There were different ways, right?
Right.
Like intentions.
Right. First intention healing. Think of a clean surgical cut. The edges line up nicely, get stitched or glued.
Minimal scarring, usually.
Exactly. Then second intention, This is for wounds with significant tissue loss, or maybe they're left open because of infection risk.
So they heal from the bottom up.
Granulation tissue fills it in gradually, takes longer, more scar tissue.
And third intention.
That's kind of a delayed closure. You might leave a wound open intentionally for a bit, maybe to let it drain or clear an infection.
And then close it up later, like first intention.
Yeah. Precisely. Once it looks clean and healthy.
Got it. And the fluid, the exudate, that comes out of wounds that tells us things too.
Absolutely. Serous sanguineus, it's clear or pale yellow, usually normal. Serous sanguineus is pinkish, a mix of serous fluid and a little blood, also pretty normal early on.
Okay. Sanguineus is just red, more blood.
Right. And hemorrhaging is, well, active, significant bleeding. Not good.
And purulent exudate. That's the bad stuff.
Usually means infection. It's thick, often yellow, green, maybe grayish. Smelly sometimes too.
So tracking the healing phase, the type of intention, the exudates, it all paints a picture for assessment.
Exactly. Crucial clinical information.
All right, so how do we figure out what's actually causing a skin issue? Diagnostic tests.
Yeah, several key ones. A skin biopsy is common, taking a small piece of skin to look at under a microscope.
Different types, punch, excisional.
Right. Punch uses a little circular tool. Excisional removes the whole lesion plus a margin. Shave biopsy just takes the top layer.
And before that, consent, cleaning the area.
Essential. Afterwards, handle the specimen carefully, send it to the lab, sterile dressing on the site, watch for bleeding or infection.
Patients need instructions, right?
Yeah.
Keep it dry for a bit, clean it daily, maybe antibiotic ointment.
Yep, typically dry for at least 8 hours, then daily cleaning. Ointment if prescribed. Sutures usually come out in 7-10 days, and definitely tell them to report any signs of infection, more drainage, redness.
Okay, what about cultures? Skin or wound cultures?
Those help identify bacteria, viruses, fungi causing trouble. You can get a sample by scraping, a punch biopsy, or collecting fluid. Sometimes even a nasal swab for things like MRSA.
Might need local anesthetic.
Possibly, yeah. And here's a key thing. If it's a viral culture, get that sample on ice immediately.
Why is that?
Keeps the virus viable for the lab. And, super important, always try to get cultures before starting antibiotics.
So the antibiotics don't mess up the results.
Exactly. You want to know what you're treating before you treat it.
Makes sense. What's diascopy?
Oh, that's a simple one. You just press a glass slide firmly on a skin lesion. It blanches the area, pushes the blood out temporarily, so it removes the redness, and you can see the underlying lesion characteristics better. Non-invasive. Pretty useful.
And of course, just a good old-fashioned visual inspection and feeling the skin. The general assessment.
Can't skip that. Color, texture, moisture, temperature, thickness, tenderness, all part of the picture. We covered the full assessment details back in Chapter 13, remember?
Right, yeah. Okay, let's dive into some specific conditions. Candida albicans.
Common fungal infection. Yeast infection, thrush. Same thing, different location. Affects skin and mucous membranes.
Who's most at risk?
People with weakened immune systems, maybe HIV, transplants.
Yeah.
Also, long-term antibiotic use can disrupt the body's normal flora.
Allowing the yeast to overgrow.
Exactly. Diabetes, obesity also increase risk. Common spots are mouth, perineum, underarms, under breasts, warm, moist areas.
And what does it look like?
Skin can be red, itchy, maybe sting a bit. In the mouth thrush, you see those red areas with whitish, sort of cottage cheese-like patches.
Okay. Interventions. Keep things clean and dry.
Especially skin folds. If someone's hospitalized, frequent checks, repositioning, keep linens dry. Good mouth care for thrush is vital.
Avoid irritating foods or mouthwashes.
Yeah. Tepid, non-irritating stuff. And then antifungal meds, topical or oral, are usually needed.
Got it. What about herpes zoster shingles?
That's the chickenpox virus. Varicella zoster, coming back later in life. Usually when the immune system is down for some reason, stress, illness, age.
So it hides out in the nerves after you have chickenpox.
Yep, in the dorsal root ganglia, near the spine. When it reactivates, it travels along that nerve path to the skin, causes that painful, blistering rash in a specific area, often following a nerve line.
Diagnosis is usually visual.
Often, yeah. But a Zank smear or viral culture can confirm it.
And the nerve pain can linger afterwards. Postherpetic neuralgia.
Yeah, that can be a real problem lasting months or even years. And shingles is contagious to people who haven't had chickenpox or the vaccine. They can get chickenpox from the blister fluid.
Important distinction. This isn't the same as herpes simplex, cold sores, or genital herpes.
Correct. Different virus. Key signs for shingles. Those unilateral clusters of vesicles, small blisters following a nerve path, often on the trunk, chest, or face.
And maybe fever, feeling generally unwell, burning pain, itching.
Paresthesia, that pins and needles feeling too.
Because the blister fluid has the virus, isolation is needed.
Right. Standard precautions plus contact. Maybe airborne if the lesions aren't covered until they crust over. Nurses need to watch for secondary bacterial infections, eye problems, skin necrosis.
Neurovascular status too, if it's on a limb. And maybe Bell's palsy if it's on the face.
Good point. Check cranial nerve 7. Comfort is key. Air mattress, bed cradle, keep the room cool. Warmth can make the pain worse.
Discourage scratching, obviously. Loose cotton clothes.
Yeah, avoid wool or synthetics.
Yeah.
Astringent compresses might help dry things out, keep it clean, and administer the prescribed topical and antiviral meds.
There's the vaccine too, right, for older adults.
Yep, for 60 and older, helps prevent it or lessen the severity. And antivirals are key for active infection. Chapter 60 has more on the meds.
Okay, let's talk MRSA, methicillin-resistant Staphylococcus aureus.
Nasty stuff. Staph bacteria resistant to common antibiotics can be community-acquired, think sports teams, close contact.
Or hospital-acquired surgical sites, devices.
Exactly. High-risk patients might get screened with a nasal swab. If someone has it or is a known carrier, contact precautions are crucial in healthcare settings.
And it ranges from mild skin stuff like folliculitis or boils
To really serious systemic infections, sepsis, organ damage if it gets into the bloodstream. And it's contagious via direct contact.
culture insensitivity test confirms it and guides antibiotic choice.
Absolutely critical. Nursing focuses on preventing spread, standard and contact precautions, meticulous hand hygiene. Monitor closely for worsening infection. Chapter 37 has a deep dive on MRSA.
Okay, erysipelas and cellulitis. Sounds simple.
They are related. Erysipelas is more superficial dermis and lymphatics. Spreads fast, usually group A strep, getting in through a break in the skin.
Cellulitis goes deeper, dermis and hypodermis.
Right. Often strep or Staph aureus. Both cause pain, tenderness, redness, warmth, swelling, maybe fever.
Treatment involves rest, warm compresses.
Yep. Antibacterial dressings or ointments locally, and systemic antibiotics are essential. Ideally, get that culture before starting the antibiotics.
Makes sense. Okay, poison ivy, oak, sumac. Everyone hates those.
Urushiol oil contact dermatitis. Classic sign is those papulovesicular lesions, itchy bumps turning into blisters, and severe itching.
First step, wash it off immediately.
Crucial. Soap and water, thoroughly. Cool, wet compresses help the itch. Over-the-counter stuff like calamine or hydrocortisone can help too.
Severe cases might need prescription steroids, topical or oral.
Yeah, if it's really bad.
All right, bites and stings. Spiders first. Most are harmless.
Venomous, technically, but usually not harmful to us. Big exceptions. Brown recluse, black widow, tarantulas too. And always think about tetanus prophylaxis if the skin is broken.
Brown recluse causes that necrotic lesion. Loxoscelism.
Yeah. Ice immediately and intermittently for up to 4 days helps limit the damage. Antiseptics, antibiotics if it gets infected secondarily.
Black widow, small bite, but neurotoxic venom. Muscle pain, spasms.
Right. Ice again, immediately. Systemic effects are possible, might need hospital care.
Tarantulas,
Yeah.
local swelling, pain, numbness,
Yeah.
and those barbed hairs.
Yeah. The hairs can cause nasty inflammation. Need to remove them carefully. Sticky tape, irrigation. Elevate, immobilize, maybe antihistamines or corticosteroids. Tetanus update.
Scorpions. Mostly local pain, but the bark scorpion is dangerous.
Very. Neurotoxic venom can be fatal. That's an immediate ER trip, antivenom needed. Most others are managed with pain relief and wound care.
Bees and wasps. Local reaction, but anaphylaxis is the big danger for allergic folks.
Exactly. Get the stinger out quickly. Scrape or brush, don't squeeze. Ice pack. If someone's allergic hives, swelling, trouble breathing, that's an emergency. EpiPen if they have one. Call 911. Always carry 2 EpiPens if prescribed and seek care even after using one.
Snake bites.
Yeah.
Depends on the snake, venomous or not.
Yeah.
First aid.
Move to safety, rest, immobilize the limb below heart level. Remove tight stuff like rings. Keep warm, no alcohol or caffeine. Constricting band only if help is really delayed, and monitor circulation closely.
What's that, dude?
Don't cut, don't suck, don't use ice. Get to the ER immediately for possible antivenom. If safe, maybe bring the snake in a sealed container for ID.
And for any worrisome bite or sting, call poison control.
Always a good first step for guidance.
Okay, shifting gears to cold injuries. Frostbite.
Tissue damage from freezing. Fingers, toes, face, nose, ears, or common spots.
Different degrees, right?
Based on depth.
First
Okay.
degree, white plaque, redness, swelling. Second degree, large, clear blisters. Third degree, smaller, maybe bloody blisters, then Escher, a dead tissue, deeper damage. Fourth degree, full thickness necrosis, down to muscle bone, risk of gangrene, amputation.
First aid is rapid rewarming.
Yes, continuous warm water bath or towels, 104, 107.6 degrees Fahrenheit. Handle very gently. Immobilize.
What to avoid?
No dry heat, no rubbing or massage causes more damage. Rewarming hurts, so analgesics are needed. Loose sterile dressings afterwards, avoid compression. Monitor for compartment syndrome. Tetanus, antibiotics might be needed. Debridement or amputation for severe cases.
Okay, what about long-term sun damage? Actinic keratosis.
Rough, scaly patches from chronic sun exposure, face, scalp, arms, hands. Important because they're precancerous, can turn into squamous cell carcinoma.
Treatment options. Meds, freezing, scraping.
Yeah, topical meds, excision, cryotherapy, curettage, laser. Chapter 40 covers the meds.
Which leads us to skin cancer itself.
Yeah.
Malignant growths can metastasize. Main cause.
Sun overexposure, overwhelmingly. Other risks. Chronic irritation, genetics, radiation, fair skin, older age, outdoor work, chemical exposure. Diagnosis is by biopsy.
3 main types.
Basal cell carcinoma, most common, from basal cells in the epidermis. Rarely spreads, but can destroy local tissue. Squamous cell carcinoma from epidermal keratinocytes, more likely to invade and spread to lymph nodes.
And melanoma.
The most dangerous. Can arise anywhere, often in moles. Highly metastatic brain, lungs, bone, liver. Early detection is absolutely key for survival.
Assessment focus.
Yeah.
Changes in moles or lesions. Color, size, shape, itching, soreness.
Exactly. Education is huge here. Sun risks, monthly self-exams.
Nursing interventions. Reinforce prevention, teach self-exams, monitor lesions, remove irritated moles, avoid irritants, sun protection.
All of that. Sunscreen, protective clothing, avoid peak sun hours, 10 a.m., 4 p.m. Support through treatment, whether surgical or medical. Explain procedures like cryosurgery, excision, etc.
Let's talk psoriasis. Chronic, inflammatory, not infectious.
Right. Skin cells reproduce way too fast, causing those thick, scaly patches. Psoriasis vulgaris is most common. Cause is complex genetics plus triggers like stress, trauma, infection, hormones, obesity, autoimmune issues, climate. Some meds can worsen it.
Kubner phenomenon, new lesions at injury sites.
Yep. And some get psoriatic arthritis, joint inflammation. Goal is to slow cell growth, reduce inflammation. Treatment depends on severity and response.
What do we look for? Itching, silvery white scales on raised red plaques, common spots like scalp, knees, elbows.
Extensor surfaces, sacrum too. Nails can get pitted, yellow, thick. Joint pain if arthritis is present. Chapter 40 again for pharmacology.
Nursing care. Emotional support is big. Body image issues. Use prescribed therapies only. Avoid scratching. Keep skin lubricated.
Yes, absolutely. Monitor for secondary infections. Light cotton clothes help. Stress reduction strategies are good too.
Okay, acne vulgaris. Chronic. Starts around puberty. Often worse in males. Face, neck, chest, back, shoulders.
That's the pattern. Needs active treatment until it resolves. Lesions range from comedones, blackheads, and whiteheads,
To inflamed pustules and papules.
and deeper, painful nodules in severe cases, which can cause scarring. Cause isn't totally clear. Androgens, sebum, P. acnes, bacteria all play roles. Flare-ups linked to menstrual cycles, oily skin, genetics possibly.
Assessment involves identifying the lesion types.
Right. Whiteheads, blackheads, inflamed pimples, deeper nodules.
Interventions. Gentle cleansing, no scrubbing. Use prescribed topicals. Don't pick or squeeze.
Crucial advice. Use non-comedogenic water-based products. Avoid oily stuff. Follow-up is important. Meds are in Chapter 40.
Stevens-Johnson syndrome, SJS. Sounds serious.
It is rare but serious medication-induced immune reaction. Skin and mucous membranes. Common triggers. Some antibiotics like sulfa drugs, anti-seizure meds, NSAIDs.
Similar to 10, toxic epidermal necrolysis.
Yeah, SJS is considered a less severe form of 10. Both involve widespread redness, blistering, skin shedding.
Mild to severe. Vesicles, erosions, crusts. It can affect eyes, respiratory, renal systems.
Yeah.
Even fatal.
Yes, severe systemic effects are possible, including blindness. More common in cancer patients, chemo, immunotherapy, immunocompromised folks. Starts like the flu, then the rash, can get ulcers and larynx, bronchi, esophagus.
Vein treatment. Stop the offending drug immediately.
Absolutely. Then supportive care antibiotics for secondary infection, maybe corticosteroids, fluids, wound care.
Okay, let's shift to pressure injuries, a huge nursing concern.
Definitely. Skin and tissue damage from prolonged pressure, usually over bone or from a device. Cuts off blood flow, ischemia, inflammation, tissue death. Hard to heal once they start. Prevention is key.
Risk factors. Pressure, shear, friction, immobility, poor nutrition, incontinence, decreased sensation.
All major contributors. Staging is detailed in Table 39-2.
Key intervention: don't massage red areas.
Right, can cause more damage. Identify high-risk clients early. Implement prevention. Positioning, pressure relief surfaces, good nutrition, hydration, skincare.
Check skin often. Keep it dry. Smooth sheets. Change promptly if incontinent. Use barrier cream.
All essential. Turn and reposition immobile patients, usually every 2 hours, maybe more often. Range of motion exercises.
If an injury is present, document location, size, depth, exudate type mount, undermining, tunneling.
Yes, detailed assessment. Serous sanguineous exudate might be normal initially. Purulent means infection. Follow facility protocols for assessment and treatment. Dressings, debridement, maybe grafting.
Other treatments: wound VAC, hyperbaric oxygen.
Electrical stimulation, topical growth factors, various options depending on the wound.
Finally, burn injuries. Priority actions box highlights airway, oxygen, vitals, IV fluids, elevate limbs, keep warm, NPO initially. Goals: prevent shock, preserve organ function.
Spot on. Burns destroy cells via heat, friction, electricity, radiation, chemicals. Size matters. Small burns are local. Large ones, 25% TBSA adult, 10% child, cause systemic response.
Estimating size: rule of nines, figure 39:1.
Common method. Depth is also critical.
Yeah.
Superficial thickness, epidermis only. Red, painful, no blisters. Superficial partial thickness, epidermis. Blisters, wet, shiny, very painful. Deep partial thickness, deeper dermis. Maybe no blisters. Red or white patches may or may not blanch, can worsen to full thickness. Full thickness, epidermis, dermis destroyed, needs grafting, dry leathery eschar, white, red, yellow, brown, black. Reduced absent sensation, deep full thickness beyond skin to fascia muscle bone. Black, no sensation, needs extensive treatment grafts.
Age and health status matter too. Young and old, pre-existing conditions increase risk.
Definitely higher mortality. Burn location is also key. Head, neck, chest, respiratory issues, face, corneal abrasion, ears, chondritis, hands, joints, eat disability risk, perineal infection risk, circumferential limbs, vascular compromise compartment syndrome, circumferential thorax, ear breathing problems.
Inhalation injuries are a big worry. Smoke inhalation.
Major respiratory threat. Look for facial burns, swollen throat nose, singed nasal hairs, stridor, wheezing, hoarseness, sooty sputum, fast heart rate, agitation.
Carbon monoxide poisoning too. Colorless, odorless, steals oxygen from hemoglobin.
Exactly. Creates carboxyhemoglobin, causes tissue hypoxia. Table 39-5 shows levels and symptoms. Direct heat injury from steam hot liquids affects airways too. Redness, swelling, blisters, ulcers. Upper airway obstruction is a risk, especially first 24-48 hours. Watch head neck burns closely. May need intubation.
Burn pathophysiology. Complex chain reaction. Increased capillary permeability, edema, low blood volume, poor organ perfusion, a fast heart rate, low BP.
Right. Initial low sodium, high potassium, high hematocrit then low urine output then high, decreased GI blood flow, depressed immunity, high infection risk, lung issues, fluid loss, risk of hypovolemic shock.
Management phases: resuscitation, emergent phase, table 39-6. Pre-hospital, safety, ABCs, trauma check, keep warm, cover burn, remove tight stuff, IV access, transport, ED, continue care, major burns, assess extent depth, airway, 100% O2, monitor distress, maybe intubate, check throat, ABG, scarboxy, hemoglobin, keep O2 on until 15% if inhaled, IV access, non-burn skin or central line, monitor for shock, fluids, vitals, Foley, aim 30-50 milliliter, MPO, NG tube, tetanus, IV pain meds, prep for escharotomy, fasciotomy if needed. Minor burns, pain meds, tetanus, wound care, follow-up.
Then the resuscitative phase, table 39-6. Fluid resuscitation, guided by urine output, 30 to 50 milliliter rate. Success, stable vitals, good urine, palpable pulses, alert. Titrate fluids based on outpeel electrolytes. Monitor airway edema, respiratory status. Pulse ox, ABGs if inhalation. HOB 30 plus degrees for head face burns. Watch for fluid overload pulmonary edema, ECG monitor. Monitor temp infection. Protective isolation is key. Strict hand washing, sterile supplies, PPE. Clip hair near wounds. Daily weights. Big gain for 72 years is expected. Monitor NG output pH. Stress ulcer risk. Maybe antacids as tube blockers. Check bowel sounds, distension, occult blood. Check urine for myoglobin. Monitor INO closely. Notify provider if urine 30 or 50. Elevate burn limbs above heart. Check distal pulsus gap refill and circumferential burns frequently. Warm room. Special beds cradles. Pain management. 4B route preferred. Avoid MSQ. Nutrition is vital. High metabolic rate. NPO till bowel sounds, then clears advance. May need tube feeds TPN. High protein carb fat vitamins. Monitor calories, weights. Escharotomy. Incision through eschar for circumferential burns to relieve pressure. Bedside, usually no anesthesia. Check circulation post-op. Control bleeding. Fasciotomy. Deeper incision if escharotomy isn't enough. Done in OR. Similar post-op checks.
Acute phase, table 39-6. Continue protective isolation, wound care, Prep for closure, pain control, nutrition. Start thinking rehab.
Wound care involves cleansing, debridement, dressings. Hydrotherapy, add 30 min, maybe, but watch electrolyte stem pain. Medicate before. If no hydrotherapy, wash, rinse in bed. Debridement removes dead tissue. Mechanical, washcloths, forceps, wet to dry. Enzymatic, topical enzymes. Surgical, excision in OR, tangential or fascial.
Wound closure needed to prevent infection, fluid loss, contractures, usually day 521. Coverings, box 39-3. Biologicals like amniotic membrane, allograft, cadaver skin, xenograft, animal skin are temporary. Cultured skin is fragile. Autograft, patient's own skin is permanent. Artificial skin, biosynthetic dressings, synthetic dressings are other options. Autografting is surgery. Post-op monitor bleeding under graft, immobilize 3 to 7 days. Elevate, care, no pressure weight bearing. Gently roll out exudate if ordered. Monitor for infection hematoma. Avoid harsh detergents. Lubricate skin. Protect from sun. Splints garments maybe. Donor site care. Varies. Keep client-free, no pressure scratching. Heals in 7-14 days, can be reused. Lubricate after healing.
Physical therapy starts early in acute phase. Splinting, positioning, exercises, ambulation, ADLs. ROM for EDA mass strength function. Ambulate for leg strength. Splints prevent contractures. Static versus dynamic. Scarring managed with pressure wraps garments. Worn 23 Thiers's Day for 18 mode years.
Rehabilitative phase.
Right.
Table 39-6. Final phase, goals, promote healing, minimize deformities, increase strength function, emotional support.
And that critical thinking scenario, what should you do about the autograft care? Page 502 emphasizes elevation, immobilization, keeping it pressure-free, no weight bearing, managing exudate as ordered, and monitoring for infection.
Right. And the chapter wraps up with those NCLEX practice questions. They hit key topics like rule of nines, shingles contagion risk, differentiating skin cancers, prevention education, frostbite pressure injury signs, psoriasis characteristics, MRSA precautions, inhalation circumferential burn management, fluid resuscitation adequacy, and herpes zoster diagnosis. Definitely review those and the rationales.
So wrapping up, we've really covered the integumentary system in detail, following Chapter 39 from Saunders. Structure, function, a whole range of disorders.
Yeah, we stressed that link between the skin structure and its protective functions, and how knowing that helps nurses recognize and manage all these conditions we talked about.
From common infections like Candida and MRSA, viruses like shingles, inflammation like psoriasis and acne, all the way to severe trauma like frostbite and burns. We tried to hit the key risk factors, assessment points, and nursing interventions.
And hopefully this knowledge is practical, whether you're studying for the NCLEX, already practicing, or just want to understand your own body better.
Absolutely. So here's a final thought for you to mull over. Thinking about the skin as that primary barrier, that interface with the world, what are some less obvious, maybe daily things we do or environmental factors we encounter that might unintentionally weaken its integrity? Something to consider.
Good question. And just to confirm, this deep dive has covered the entirety of Chapter 39 from Saunders Comprehensive Review for the NCLEX-PN Examination, 7th ed, key concepts, assessments, procedures, safety, priorities, and those review questions, clarifying medical terms along the way.